Hello, everyone, and welcome to the 15th Business of Healthcare show, HCBiz. We started this way back then 15 weeks ago to talk about how do we get some of these cool, innovative things that the internet's always talking about into play. And our premise is simply that you can't just jam this stuff out there. That you need to have good working, good, well-operating businesses that have some space for innovation and some space to take some risks. And we need to keep in mind that these are businesses and that these are folks and their livelihoods, and they need to find a way to incorporate all these great new tools and techniques and processes into the business while still satisfying the fee-for-service stuff that's going on, making some money for themselves and their families, and keeping their patients healthy. So that is the basis for our show every week. And this week we want to talk about a couple of things. Really, it all came from a study that was released. Some folks from the Dartmouth Institute and a couple other places collaborated on, funded by Commonwealth. And they went out and interviewed some physicians to find out if they were aware of this Choosing Wisely program first, which comes from the ABIM, American Board of Internal Medicine. And what it is a group of, not a group of, but they get all of the specialty groups together, and those folks put out recommendations for what are the types of treatments that aren't necessary, or at least that you should think twice about and under certain circumstances. They got these big long lists of guidelines, and they're specific to each of those specialty groups, and it's been around since 2012. So this group went out and said, are people aware of this? Are they taking advantage of it? Do they see value in it? And that showed some interesting results, which we can talk about. But they took an interesting turn on it as well and went beyond that. Should we be thinking about what's necessary, unnecessary, but should we expect doctors to know and understand what things cost and take that into consideration too when they're coming up with these care plans? So that was the basis for the questions that came out of the tweet chat today. That's the stuff I'd love to get into with you guys here. So Dr. Mike, welcome, and Chuck Wereflow, welcome.
Thanks, good to be here.
Awesome. So I guess that's a good place to start, is this Choosing Wisely initiative from ABIM. Have you heard of it, Dr. Mike?
Yeah, heard of it. I don't pay a whole lot of attention to it for a couple of reasons, one of which being that our own academy, my subspecialty of otolaryngology, ear, nose, and throat, does pretty much the same thing. And, we've had discussions for a long time, and part of it is because we've had some very hot button issues on this. And I think one of them is in the Choosing Wisely thing, which is this avoidance of antibiotics for sinusitis-like symptoms if it's only been a couple of days.
Right.
And, that's always been a big one for us. And when I first came into practice 20 years ago, the demand for antibiotics, if you had a runny nose for a couple of days, was fierce. And the problem was really coming from patients, because there was this widespread belief that, the stronger the antibiotic you gave, the better the doctor you were. And if you went into a speech and said, look, you've only had symptoms for 2 or 3 days, it's probably viral, you don't have the cardinal symptoms of true sinusitis that we look for. It was not unusual back before 2000 just to have a patient walk out of the office in a huff, because they were, or even among primary docs, the same sort of belief. That's gotten much better, for this particular parameter over the past 20 years. But, conceptually, I like the idea of coming out and saying, here's what you really don't need to do. And then, it's got to be, made public and go beyond just the medical community, because a lot of times it's like it used to be with us and runny noses, that it was a big push from the patients where the demand was coming from, not some evil doctor over treating something.
Got it. Yeah, that's in my reading on this, and sure, I was looking at it from the Choosing Wisely standpoint, but to your point, this isn't new, putting out guidelines for this type of thing, and the consensus of the doctors was that sure, it's good to have this information in front of us and to think about this when it comes in, but they all alluded to the antibiotic issue, and they all alluded to the patient demand for it. And some of the flow that I was seeing was, if I'm a physician and I'm, running behind schedule and I get into that room and I already have this huffy patient, they were admitting that basically there's a lot of pressure to give in and give the person what they want, because that's going to help them get on to the next case and not get further behind in the day. So they weren't saying that was good to do. They were just admitting that this is the reality. These are the decisions I have to face on a day-to-day basis. So,
absolutely, that happens where you're getting behind, the waiting room's full, the exam rooms are full, and it's like, okay, fine, I punt, I give up here.
Yeah, right. I can definitely see that.
And that's we've all been there, and so that can be. It's gotten better in the last few years. There's been enough public awareness of not only the medical inappropriateness of antibiotics in many of those settings, but the potential for antibiotics to cause harm. Like Levaquin and the Achilles tendon stuff. And, there's a lot of things out there where antibiotics can cause side effects, breeding of resistant strains of bacteria, that kind of stuff. And so public awareness has gone up on that. And at least for that particular parameter, things are better than they used to be. But when I was reading some of the stuff you'd put out in advance of the blab, Don, there was also there was a question about how aware doctors need to be about cost issues across the board.
Yes.
Which I thought was interesting. I'll just let you go into that.
Sure. That was actually what sent me down this path. Is I was out a couple days ago, just going through on Twitter. We got another caller, and let me just let them in. Gary 11. I just bounced around on Twitter and I saw a tweet from somebody. It was a physician, and basically, how you doing, Gary? What he said was he was responding to the study because somebody tweeted, most doctors unaware of the cost behind the care that they give, and his response, and he was a physician, was, we're too far separated from that. And if we were more aware of it, and we would naturally take that into consideration, and it would transform our practices. He said that in 140, obviously, and that's what kind of sucked me into the study. And I started reading about it, and that's the question is just that. It's kind of a blend of could we, like, I know it's a crazy complex issue. How could we even go about making everybody aware of the healthcare costs? And this is where Chuck, you should dive in with some of your commentary on the price versus cost, because as you pointed out, that muddies the water too. So that was kind of the gist of the whole conversation, was like, how could we do this, and then should we do this? And I wanted to get people talking about it and see what the thoughts were.
Well, Chuck, you jump in and tell me what you think about this, but it's, at the risk of sounding like a broken record, once again, have evil of the third-party payer system. And we run smack up against this in two situations. One is that when we're trying to recommend surgical options, that we have no idea what anything costs. And we've been able to improve on that a little bit with our own ambulatory surgery center, because we can then say, here's what the list price on the surgeon fee is, which is largely fiction. Here's what the cost of anesthesia is. Here's what the facility fee is, and kind of give them an idea. But if they're going to the hospital, they will not discuss cost in advance at all. They say, don't even ask, because we don't know how long you're going to be here, when your doctor's going to discharge you, all this kind of stuff. And so when patients want to know how much a sinus surgery, say, is going to cost, if we're doing it at the hospital, we have no idea. And, I've had patients walk out because they say, look, I can't agree to do this if I don't know what the costs are going to be, or at least an estimate up front. And I totally sympathize with that point of view. We do what we can. Sometimes with prescriptions, we have some things that have been prescription for years, and now they're over the counter, stuff like Flonase and some of the proton pump inhibitor antacids. And what I'll do is give them a prescription and say, price it out. If it's cheaper over the counter, buy it over the counter. If it's cheaper with a prescription, depending on your drug benefits, use the prescription. So, we're aware at a conceptual level, and we do what we can, but because, a third-party payer system ensures that nobody knows what anything is going to cost, not the doctors, not the patients, not anyone else, it makes it very hard to make any, I hate to use the word meaningful anymore in this modern age, but it's hard to make any progress in that regard.
Gentlemen, can I make a suggestion? I mean, if for those of you who don't know me, my name's Gary Levin. I'm a retired ophthalmologist in Southern California. And I think doctors have a big role to play here with administration, and actually can put some pressure on them to insist on having them tell patients what it's going to cost. And you can use your arm, the doctor's ultimate arm. I'm not going to refer patients to your hospital unless you comply with this. If you got the medical staff together and presented this to the medical staff, to the hospital's administration, I think it would bear some weight. It might take some time, but I think that's a tool that the doctors should use.
Okay, interesting. And that seems like it would have some weight coming from the independents, but that probably won't play well for those that are more closely tied to the hospital. There's
right, I agree.
A little bit more control. So can you talk about that a little bit?
Well, I don't believe the hospital can't give some estimate. I think most patients don't want an exact figure, but they have enough data now to have an idea within a certain, standard deviation of what a certain thing is going to cost a patient at the hospital or freestanding surgery center. I think it's just a matter of obstinance and a resistance to change.
Mm-hmm.
Oh, I agree. I mean, in our surgery center, we can give them cost up front. We break it all down and say, here's what the prices are, here's what the patient's responsible for, here's what the insurance is going to cover. And, if the numbers don't work for the patient, then, they don't have their surgery if it's not something that's, a life-threatening issue. And I agree, Gary. I think it's, the hospitals probably can. They choose not to. I'm not as optimistic regarding the ability to force the issue because, at least in a big urban market like Atlanta, where there might be 1,000 doctors on staff and, ear, nose, and throat's not a high-volume specialty. So if you're not cardiology and you're not orthopedics, and you're not one of the huge groups, then they're just going to say, hey, that's the way it is. And, don't let the door hit you in the rear end on the way out if you don't like it.
Well, I think what's happening is with healthcare reform and the Affordable Care Act and accountable care organizations and the whole alphabet of things that are coming down the pike, I think the federal government is going to start regulating this, that they're going to insist the hospitals have openness, transparency. That's the word these days. They've got openness and transparency now with the electronic health record. It's part of meaningful use, and I'll bet this happens in the hospital environment as well.
Yeah, in Massachusetts, there's something going on with that right now. I don't know the specifics, but it is something about prices having to be published on websites ahead of time. Chuck, you actually had an interesting comment on this during the tweet chat. I think you dubbed it meaningful cost transparency.
Meaningful cost. Hashtag meaningful cost. Starting a program to force cost transparency through some kind of top-down federal mandate would probably be about as successful as meaningful use was in creating usable, interoperable systems. And so I'm not. And the conversation we've had here, you can see that we're flipping back and forth: price, cost, price, cost. The cost to the patient is a price of that organization, and Mike's organization has set various prices, and so you can estimate the cost to the patient. The big problem is that most healthcare organizations really don't know what their costs are for service lines. They don't know exactly how much an appendicitis costs. They don't know exactly. Well, I'll give you an example. When I was a medical student, my undergraduate degree is in accountancy from the University of Illinois, #1 ranked accounting school. I took a zillion, and cost is fascinating. It's actually a fascinating philosophical concept. But it would be too esoteric to talk about here. But what I did do was, when I showed up at the medical school, the dean of students at the University of Chicago said, you have an unusual background. What can I do help you synthesize or combine that with your medical education. They said, I'd like you to introduce me to the comptroller of the University of Chicago Medical Center. And he said, well, that's the first time anybody's ever asked for that. So he introduced me to the guy, and we had lunch. And the comptroller said, well, this is the first time I've ever actually met a medical student, face to face. What would you like? And I said, I'd like to understand your cost accounting system. I'd like a tour. I'd like to see the workflows, where you get your data, how your reports work. And I was very, very nice, but I was absolutely horrified because basically it violated every fundamental theory of cost that I had learned in my undergraduate degree in accounting. And because they basically allocated overhead costs and they changed the formula from square feet to light bulbs to whatever maximized their revenue. So basically, and that's kind of that's now the basic problem is that costs in healthcare are so labor intensive. So you've got the 70 or 80% that's due to expensive labor, and every sort of service line is a sequence of activities, a sequence of tasks. And so there's the pre-op set of tasks, there's the operation, there's the post-op, and so forth. And each of these tasks has a frequency, it has a duration during which it's consuming stuff, and then it has the cost of the actual resources. And we really don't have that kind of what's called micro-costing or activity-based costing models. So a part of the reason that I'm convinced, although I've been in some pretty vehement debates, I'm convinced that part of the reason we don't have price transparency, part of the reason that healthcare organizations don't like to quote a price, is they don't know what their costs are. And if you don't know what your costs are, you're paranoid that if you don't charge enough, you're going to go out of business. But if you knew what your costs are and you know that the price you charge is, let's say, if you know you have a positive margin, 20%, you're going to be much more likely to actually quote that price. But that's kind of that's based on intuition and no research study that I know of.
Dr. Webster, with your background in accounting, I cannot argue with your figuring out how they do this, but I have a simple thing. Keep it simple, stupid. KISS. I don't see why they can't look at what the bills are going out for each patient. Look at that number, take an average, and just post it. Say, this is the average cost.
Yep.
It's simple. It's straightforward. Like when my wife ran my office, I bought a computer. So what do you need this computer for? Look at your checking account, see how much money's in it. See what your bills are, subtract them out. Look at your waiting room. How full is it? So she hated computers, but that was actually worked out to be pretty equal. I didn't know exactly where things were going, but
that's one way of doing it. But I think you would agree that actually knowing what your actual costs are internally, so that you know whether you are making money or getting enough money in the door to invest in various capital projects, would be useful.
Well, I agree they are useful. I don't think they're useful for predicting the price, but predicting what it will cost down the line. But you can tell a patient what it's cost an average patient that's had the procedure in the last 3 years.
Well, there's a good reason why they don't do that, Gary, and it's sad, but it's true. And this circles back to David Goldhill's book that we've talked about, the book on catastrophic care, and that is that we don't set prices, right? The insurers set the prices. And so the only way that entities can document that they need to be paid more money is to pay fast and loose with the accounting to make things look like they're more expensive than they really are. And so the example that Goldhill uses in his book is the neighborhood lemonade stand. And I'll try to make this fast. But the idea is that somebody comes through and says, I'll buy all your lemonade, and I will pay you at cost plus 10% for your lemonade. So what are you going to do? You're going to roll everything into your costs. You're going to buy a new lemonade table, and you're going to buy the best ice you can buy and the best water you can buy so that you can trump up that cost as high as you can go. And because 10% of that number is more profit. So when health care entities go to insurers and say, you need to bump up what you're paying us for a hernia repair, and the insurers say why, they've got to go back to their books and say, well, here's what it's costing us, and it's costing us more than you're paying us. But there's a reason why it can't be that simple. And again, for the risk of sounding like a broken record, it always circles back to a system that doesn't let the patient and the doctor collaborate and set a price between them.
Right.
Always somebody else.
That's a great segue. The next question I wanted to ask you guys is from a standpoint of a hospital or a provider publishing pricing. Isn't the pricing different depending on my payer? And as a patient coming in, I have one of 10, 15, 20 different payers that you're participating with, and that price range is going to be different depending on how that negotiation went down between that hospital and that payer. So does the sheer fact that it's hard to keep track of that make it so that they don't want to have this conversation with patients, or is there something else to it?
I may speak to that. I have a personal experience with that. My wife recently had a very bad head injury to which she unfortunately succumbed. And we had an HMO, Humana, and they paid, I think, $35,000 for a 2-day stay in the hospital. I got the bill. The bill they sent to the insurer was $250,000, and they paid them $35,000. I don't know how they can justify the figure. I'm sure it's for accounting purposes to figure out what's going on, but that is kind of untruth that makes people very uncertain about what's really going on.
Yeah. Well, what's happened is that the accounting systems have become a way to game the system in order to maximize revenue instead of what they are supposed to be used for, which is for a veridical, truthful, objective model of cost that can be used for managing your operations of the organization correctly. That is the way cost accounting systems are used in other industries, but healthcare doesn't use cost accounting systems that way.
No, other industries, certainly if another industry did this, they'd be called corrupt. It'd be corruption. So basically the hospital system is corrupt.
Or they go out of business. Apple knows down to a penny exactly how much each of its iPhones or iPods cost. Okay? Healthcare does not have any kind of similar acuity view into its cost data.
Yeah, that issue with the giant, the $250,000 number that paid out at $35,000. That's that charge master price, and that gets into a whole other ugly situation where the theory is that those charge master prices are exorbitantly high, so that when they're doing uncompensated care for folks coming in for basically they can't pay, they're coming in through the ER. They trump up those costs with those charge master costs so that it offsets profits from other areas at tax time. So there's all types of gaming being played with those things. And that's why they always say, oh, no, nobody ever pays those prices. It's like, well, yeah, we ultimately all pay for it somehow. We just don't pay it in a really direct way, a way of paying our insurance or bill, but it's coming out of taxes, it's coming out of a lot of different places. So lots of winners here.
A thought, and this comes from Mike's repeated observation, the broken record that you referred to, which I agree with, which is this third-party pricing and the games that are played is pernicious. And now this is not, I don't know what Mike would think of this, but last year I went to the American Health Insurance Plans Conference in Nashville. This year I'm going to, and it's the payers, the health insurance conference. And it's about 4,000 folks. And interestingly enough, since I go to HIMSS every year, Health Information Management System Site, which is the Health IT conference, which is a fairly corporate place. You see a lot of people in suits, in business casual, okay? Well, the Health Insurance Conference, I mean, everybody's in suit and looks like a lobbyist. I hate to say this, sure. But the point I want to make is that when you look at the Health IT that's going on at this conference, and I do things like look at every single exhibitor website and search for workflow related stuff, because that's just what I do. I'm fascinated.
That's your thing. Absolutely.
But what I'm seeing is, and it's just kind of a nucleus of an idea, but there are lots of reasons why healthcare providers, organizations might not want to do this, except that carrots are planned to try to get them to do that. And that is that health insurers are, and you can start to call this micromanagement, Okay, but health insurers are really, really interested in much more interleaving of the clinical and administrative IT systems in the folks that they pay with their own sort of IT and analytic operations. Now, there's a kind of a question here whether you can create a win-win situation or whether there's a natural incompatibility. But that's, I think there is an element there of, trying to get at cost data to do something a little more intelligent than perhaps we've done to date. But that's maybe wishful thinking on my part.
Yeah, that actually came up a week or two ago on the show. Shahid had just led a panel at an insurance show in Chicago, and he was talking about that. There was groups that were getting together and doing that. Typically, what he was seeing is that it was the insurance-run physician groups. So where they effectively had like an IPA operating as part of their organization. Those ones in particular, they were doing getting pretty far ahead of getting that clinical and claims data.
And those healthcare systems that are starting to self-insure of a sort.
Yes, exactly.
Hiring insurers and so forth.
Yep. So what the challenge is, because I talk with a bunch of payers, in particular local ones here in Western New York, and people are interested in certainly in getting that clinical data together, because just looking at claims doesn't paint the whole picture. There's just different information in there. And the issue is that there's a huge trust issue there, though. And that's why it works when you have the group underneath the insurance company. It's kind of all integrated. When it's physicians out in the community, there's two challenges that I see. One is they're not going to do anything that just applies to one insurer. So if you're dealing with, Mike, I'm sure you can attest to this, if you've got 10, 15 different insurers, you're not going to go way out of your way to do something that's going to benefit just one of them. If it could benefit all 15 of them, that would be a plus. The other is the trust factor.
I have to go here in a moment. It's
sure.
been a wonderful tweet chat and a wonderful blab. Thank you very much. And I can't believe you're already to number 15, and I probably made about half of them. Thank you very much, Don. I guess what I want to say is, you know what? I just forgot what I was going to say. So, except let me just finish and get flattering you and saying nice to meet you, Gary. And Mike, you're always. Oh, by the way, Mike.
Yes.
Okay. Andy Slavitt, what's going on with you and CMS? Anything interesting?
Yes, we are, by their description, 90% of the way of getting Andy as a guest on the Doctor's Lounge radio show.
Sweet.
Which is supposed to happen before the end of June, before the end of the comment period. I'm also trying to get him as a keynote speaker for the Technology Association of Georgia's Health IT Leadership Summit in December. So that's cruising right along. And my show for tomorrow will kind of be, our current reaction to the MIPS macro proposed rules. So I'll be burning the midnight oil getting ready for that.
Well, did you see his Health Data Palooza keynote, which was transcribed? So if you look if you search for his name and CMS, you can find the transcript keynote in which he emphasized how he is absolutely laser focused on saving the small practice.
Yeah, and that's an interesting counterpoint to what's actually in the rules. So, yeah, at some point the rhetoric will run dry and needs to be backed up by deeds. So we'll see. It's an interesting situation.
I'm signing off, and you guys please don't leave because I gotta go. Bye bye.
Good to see you, Chuck, as always.
Mike, you're in Georgia, aren't you?
Yes, sir. Sure am.
Say hello to my friend Hal Schurz. Is he still working with D4PC?
Absolutely. Hal and I talk every day. We've already had 3 or 4 emails back and forth, and I'm a big
tell him Gary Levin said hello.
I will.
Tell him Gary Levin said hello. I go way back with him when he first started that thing.
Oh, fantastic!
It's a pleasure to meet you. It's a pleasure meeting you, Mike and Don. Thank you for inviting me in. I hope I'll see you again.
Yeah, absolutely. We're glad you popped in.
It's great to get everybody together with all this social media stuff. I love it.
I think that will become a force. It's starting already.
Amen. If anyone else wants to jump in, I saw Dr. Oates join us a little while ago. I please feel free. Mike, I don't know how much time you got left here. I'm happy to go till 1:30.
My first patient's 1:10, which is about 7 minutes from now. So if you want to yak, I'll yak back. Sure.
All right. So I kind of lost my way in the transition there. I know a couple weeks ago you talked about that's where I wanted to go, the CMS stuff and East Levitt. Yeah. So there's been a ton of dialogue coming out lately about small practices and that, infamous absolutely. Table 65. No, that wasn't the thing. And ultimately what you kind of,
because he had testimony in front of Ways and Means. That was the other big thing that happened.
Yes, absolutely.
And that was where, Tom Price kind of got him there and said, look, this is a big problem. And they kind of went, well, that data is old and we've got better data that shows it's not that bad. And, yes, it's there's plenty of grist for the mill.
Yeah, no doubt. So the thing that is and I've read a bunch on it, and the thing that I keep seeing is there's not a lot of detail behind either side of this. There's no real detail being given that I've seen, at least, that explains that table that was originally, that was released, Table 65. And there's not a lot of explanation for why you shouldn't worry about it either. It's just like, don't. Have you seen details that say, well, here's specifically what was going on with that table and why it looks so bad, in particular for I think it was the 2 to 9 doc practices, we're going to get smoked on that thing.
That's right.
And they're just saying, no, it should be fine.
Right. They're saying pay no attention to the man behind the curtain, as opposed to saying, they say, we've got programs out there that are going to help the small practices. But, the reality, at least as I see it at the moment, is that, the burden for this is so high that there's no way that a small practice can do this. And unless you have an economy of scale upwards of 20 to 25 docs, that it becomes more expensive than to comply than it does to just take the hit. And the other problem is that there's no one's determined the threshold yet, right? The whole plan for this thing is for it to be revenue neutral in the aggregate, which means that they have to penalize enough people to pay for the bonuses to the ones who beat the threshold. So you got to play a game with the bell curve and set a threshold such that there are enough losers to pay for winners. And that entire paradigm is flawed. If your goal, and again, we can back up to, if your goal from their standpoint is compliance with the rules, and that just ignores whether or not the rules are worthwhile. But if your goal is to get compliance with the rules, you have to allow for a scenario where most people comply and most people should get bonused. But if you have all A students in the class and you grade on a curve, and the lowest score is a 90 and the highest score is 100, then 90 is an F.
Right.
The bell curve, and that's how this is set up to function.
Yeah,
so,
right.
Yeah, there's a lot of issues here, and it's an interesting psychology, because what's happened here, and I don't know that anyone was expecting this, or even CMS, but in prior years, PQRS was up here, and value-based was over here, and meaningful use was over here, and we never talked about the entirety of it all at once. Now you take the entirety of it and put it in one document, and everyone's going, "Wow, this is really, what's the purpose of all this?" And what I'm going to talk about tomorrow is what I call the shell game, where this stuff started, in 2007, 2008, with a discussion that was mainly about cost and access. Right. Those were the problems, 30 or 50 million uninsured, cost rising both on an absolute basis and as a fraction of GDP, and that we need to, bend the cost curve. This was supposed to be what was supposed to happen. And that got, shell game swapped. It got bait and switched into, instead of cost and access, now it's quality and value. And, why did we allow that switch to happen, and what are the consequences? And I think, MIPS is one of those things.
Yeah, absolutely. And I threw a link over on the side here to your show. I assume when you say you're talking about the shell game tomorrow, that's on the Doctor's Lounge, correct?
That's the Doctor's Lounge. Yes, I see the link. Thank you. Yes.
Yep. And there's supposedly I'm supposed to be able to drop it in the middle here, but I can't, and that's going to show up, but it ain't working for me. So I'll have to play with that later. But to everybody else, the show's fantastic. I listened to it pretty much all of them since you and I did one when I was at HIMSS.
Yes.
And I love them. I really do. I think you guys have great conversations, and I really enjoy hearing it from the people who are doing it, because the circles I run in tend to be the people who are helping the people who are doing it. And it gives you a very different perspective on things, which I like to understand it from all angles.
Thank you.
So on the, just to kind of wrap up, and we transition now into like a macro conversation, so that's fine, is last time we spoke, you were very much of the mindset that, folks needed to comment. I think, Dr. Oates is still here too. He had the same thoughts as that. Folks need to get out there and comment.
Yes.
And you were still hopeful that changes could be made. I guess in your conversations with other docs and with all the ways that you're participating in this, how do you feel about that now, a few weeks beyond that conversation, beyond the launch of the rule?
Well, there are some folks in certain corners of my universe that I think have some unrealistic expectations. I think there are some folks who think that, this entire thing can be shut down with a strong enough commentary response. And those folks need to be reminded that, the legislation that supports this is already passed. It's already law. So CMS is not free to
looks like we lost you, Dr. Mike. At least there you are.
Did you see the interruption?
I'll you're back now.
Folks are convinced that enough pushback will make this completely go away, and that can't happen. MACRA is already a passed piece of legislation. It is already law, so their hands are tied in terms of how much they can do with that. But it does reveal another part of the shell game, which is the accountability shell game, because everybody can say, well, this isn't all mine. We have to do a certain amount of stuff. It really, if you take this occasion to comment directly to CMS and sort of broaden this to a bigger sort of, cultural, industrial pushback, that it may have more success, but it's going to take time. And it's going to take more than just a 60-day commentary period. So it's a long process. And I think the best understanding to lead to long-term success is to understand that, we're not going to hit one out of the park in 8 weeks. But, we may be able to, hit a ground ball to first and steal second.
That's a good way to look at it, because I agree. When you look for that, if stick with the analogy, if you think you're going to hit a home run every time, you might once in a while, but you're going to waste a lot of energy and opportunity along the way for sure. That approach obviously fits with the mindset of the way we try to attack all the problems here on the show. So I guess back to the one other question I did want to ask you is the commentary from Slavitt was that the small practices will do just fine as long as they can report. And so what does that mean to you? Because to me, I took that to mean that as long as they figure out how to get the, quality data together and get it into CMS so that it can be measured. Is that what he's referring to, or does that mean something else altogether?
I don't know exactly what he's referring to, Don. Saying that it'll be fine as long as you can report is like saying, you won't drown in the ocean as long as we can get rid of the water. I mean, reporting is the thorn in our side.
Okay.
That's the problem, is we can't get our IT systems to do the reporting. I talk to my administrator about that every single week, that, the reports don't work. And we go back and figure out, it's drawing from, a different field than it was before. And when they upgraded, they changed it. And the report that used to work doesn't work. And so, yes, 99% of the work is getting the reports to run. So to say, no problem, this is just all you gotta do is get your reports to work and you'll be fine, is not comforting in the least.
Okay, gotcha. Very good. So, honestly, Mike, I'm running out of my questions here for today. I think we worked through them rather than belaboring it.
After, so
I say we wrap it.
Yes.
Thank you everyone. Thank you everyone for joining us. And Mike, as always, it's a pleasure. Let's
mine.
talk soon.
Thank you. Yes, sir.
All right, everybody. We'll see you soon.
Bye.